In this year, this article introduced the dual switching monopolar radio frequency ablation using the separable cluster electrode, so-called octopus electrode. And this generator has two generators, so this figure is a comparison figure of single switching monopolar mode and dual switching monopolar mode. So single switch monopolar mode is one of three electrodes is activated sequentially, but this dual switching mode issue, you can see that two of three electrodes are activated simultaneously. So this dual switching monopolar RF ablation generator may more RF energy delivery at a given time. So you can see the upper two images with dual switch monopolar radio frequency ablation. There is well fused RF ablation, but in the lower images, you can see the notch. That means the incomplete fusion of ablation. In 2004, these articles compare the four types of commercially available devices at the time. The one is versatile perfused electrode and the clustered electrode. This is 12-tinted expandable electrode. This is 19 expandable electrode. They report that the result is the largest size of volume was made perfusion electrode, but the cooled, internally cooled electrode is more round shape compared to the other this perfused electrode, and this internal cooled electrode make constant ablation size with the small variation. So, this internally cooled wet electrode this time is made up for weak point of perfused electrode that irregular ablation size and unpredictable size of ablation is the main weakness point of perfused electrode. But this electrode is basically in the internally cooled electrode, and then water is sprayed out through the small hole in the active tip. So these two experimental and clinical studies showed that this internal cooled wet electrode results in large ablation zone and low rate of local tumor progression than RF ablation using conventional internally cooled electrode. How about the multi-tinted expandable electrode? So now using the internally cooled electrode are very popular in worldwide, all of the world. But some kind of multi-tinted expandable electrode can make the large ablation size. So this report that manufacturer's recommendation algorithm make the only 4.4 to 6 centimeter of diameter, but these authors' optimal algorithm result the size of ablation is about 5 to 7 centimeter. And another thing is this type of ablation is the sphericity ratio is about 1.0 to 1.1. That means that even though the volume, the ablation size is very large, but the shape of ablation is much round shape than the oval shape. How about the monopolar versus bipolar? As far as I know, the commercially available electrode, bipolar electrode is Celsius power system. So there are some advantage of bipolar system. The one is the bipolar RF system is the current pathway is only limited to these two electrode or one electrode. So the less systemic symptoms such as heat retention in the patient. And another advantage is that the ground pad, dispersive ground pad using the monopolar RF device is not necessary in this bipolar system. So there's no complication risk of ground pad burning. So, and this bipolar system can be used with single and dual or multiple electrodes. So this article reveals that this bipolar system is complete necrosis rate is non-inferiority of this compared with the curative RF system. So let's move on to RF ablation techniques. So the multiple overlapping technique is a traditional method to increase the size of ablation zone. There are two kinds of methods. One is a spherical overlapping method, and the other is the cylindrical overlapping method. Actually, the cylindrical overlapping method is easier to execute the RF ablation than the spherical overlapping method. But this cylindrical overlapping method is some weakness of less effective in geometrical ablation size. So even though 8-sphere model can make only 1.16 times that of each single ablation sphere. So also the clinical setting, 8-sphere ablation is very difficult due to the post-RF aquagenic change ultrasound. So I usually a maximum of 6 or 7 is enough to I cannot more ablation in the clinical setting. So it's a multiple ablation technique is very difficult method, I think. And another thing is combined RF ablation with the TACE. TACE, hepatic artery flow from artery from of HCC is occluded with TACE. That means the decreased blood flow in the index tumor. So that may reduce the heat loss and increasing the size of our ablative zone. And so you can see that this TAC and RFA is better local tumor progression rate. The last one is the lysosomal sensitive liposomal blood. You can see this case report. And this one, you can see the post 1 month follow TT shows larger RF population zone compared the immediate post-RF images. So this effect is due to this LTLD concentrating the liver and release the doxorubicin, wherever heated by RFA, and doxorubicin improved the efficacy of RFA by its tumor side effect. But this drug is a phase 3 clinical trial is finished. The result did not meet the primary endpoint that progression-free survival. However, the investigators and the company insist that after post-hoc analysis, if index tumor undergo RFA for more than 45 minutes, they clearly benefit with this LTLD drug. So I think the additional clinical trial will be needed, I think. I'll summarize my talk. The comparison type of electrode for increasing size of ablation zone. I think multiple or clustered electrodes are better than single electrode, and internally cooled wet type or some kind of multi-tint type are better for internally cooled type for larger due to make the larger ablation zone, and dual bipolar system can be larger than a single monopolar system. And RFA with the overlapping technique and combined RFA with TACE can produce a larger size of ablation zone. And RFA with the lysosomal sensitive liposomal drug may be benefited, but additional clinical trial will be needed. Thank you for attention.
Thank you, Professor Lee.
I would like to thank the organizing committee to give me the chance to share my experience with you. And my address topic today is how to prevent complication. And Dr. Minami published paper in 2011. I talk about the IBA. In the section of complication, they cite 8 papers, and most of the papers is published between 2001 and 2006. So we learned this is an old question, but we also learned that the published instance should be up to date. In the papers, they measure the major complication of percutaneous IBA is 0.6 to 8.9%. Although the instance is not so high, but it is important to prevent. Professor Livaggi conducted a multi-century study in Italy. They show the major complication of IBA, including death, hemorrhage, abscess, GI perforation, liver failure, myeloma, and biliary restriction, polar vein thrombosis, and the hemo and the pneumothorax. So, how to prevent the complications? Before IBA, we should understand the tumor location comprehensively and plan a safe needle track at the operation zone. And during the treatment, we can use the additional manipulation such as artificial ascites, fluoride using, combination with IBA and the PI, and the non-conducting method needle insertion. And after treatment, we shall monitor patients intensively and to early detection of complications and the management, if any. So before the treatment, we shall have detailed history taking. For example, biliary surgery is increase the risk of infection, and GI surgery increase the risk of GI perforation. And we also need to make some blood tests to understanding the risk of hemorrhage and to understanding the liver function reserve. We also have a detailed imaging modality to find a safe needle track and anatomical structure near the predicted operation zone. According to the information, we should adjust. Should we do the IBA or no? Or should we change to other treatment modality? And also, according to the information, we may change our strategy. Or maybe we correct some abnormality and we give some pre-medication such as antibiotics for a high-risk group of infection. During the treatment, we shall keep away from the risk structure in the needle track or within operation zone, including basal, biliary, adjacent organ. And we have to pay more attention to subcapsular tumors. So we need some additional manipulations. We can perform a artificial fluoride using, and we can insert a needle between the inspiration lung air and the expiration lung air, and we insert a needle between these two markers. And this is a smart method from Korea. They can insert the catheter between the peritoneum, inside the peritoneum. It's a nice way to perform the artificial ascites. And Professor Lin's group also published a method to inject ethanol in the danger part at the operation away from the low margin. And for subcutaneous tumor, we have two methods to increase the safety. One is a subcostal approach. The other is a non-conductive method. For this case, we insert a needle outside the tumor and make an ablation. After this operation, we insert a second needle here. So the tumor has completely ablated. without insert the needle to the tumor. And in this picture, we don't see any air inside the tumor because the tumor vessel, supply vessel, has been ablated before the air generated. This is also a subcutaneous, subcutaneous tumor. We can approach it from the intercostal. This is a subcutaneous tumor. We can approach it in the subcostal. We insert a needle from subcostal, and we observe it from the intercostal space, and we can see the needle and the complete ablation. We also prevent the direct insertion from the surface. This is a case has two tumors, has a very later aspect of deadlock, and the other tumor is near the dome, near the diaphragm. Using the fusion image technique, RVS, we can not only find the tumor, but also find the shortest ablation route. So, in such as this posterior tumor with a residual part, it's dangerous and difficult to approach this tumor. Assisted by RVS, we can insert the tumor safely and make a good ablation result using the switch controller machine. And the other method is using the EMBD to prevent the stricture of the major CBD. It also can be used in the prevent the complication. After treatment, we have to early detection the tumor the complication. We maybe recognizing the inadequate ablation during the procedure, and monitor the vital sign in the first few hours after and follow up the blood test and ultrasonography in the coming morning, and then make adequate management. And finally, I will show the three cases with a major complication. One is inadequate ablation injury to the posterior branch of right portal vein. It shows it's possible to injure a large vessel. The second case is a hemothorax after RA because we injured the intercostal vessels. And the last case, we show the case of Chelsea treated by RA and have early mortality. We find a recurrent tumor here. This is a posterior branch of right portal vein. When the needle insert, we injure the vessel. After operation, there is a air correction, is a large abscess in the second day. CT shows is a very, very large tumor. I think it is a segmental operation. So after conservative treatment, drainage, and antibiotics, the patient recovered. So in the pre-treatment, we don't recognize the risk, but during treatment, we did not perform any protection, but we know we have already injured the vessel. After treatment, we have detection the complication and good management. The second case is a very simple cases. We ablate two tumors. One is segment 7 new nodule and the segment 5 post-PEI nodule. From the CT post-treatment CT, we know it's very far away from the diaphragm or far away from pleura, but unfortunately, hemothorax dependent few hours after the IV, so we insert the drainage tube in the third day. And this case is unpredictable. Even after the treatment, we can recognize we have do something wrong. And however, we have good monitor, so we can early detection and adequate management. The last case is a patient with Chelsea, as we know, IVF can be one treatment modality as a bridging to transplant. This is two cases with Chelsea has lifespan more than 3 months. Only one single recurrence, size less than 2 centimeters. We only perform one insertion, and we also give the prophylactic antibiotics. However, sepsis developed despite the antibiotics. Case 1 expired 5 days after IVF, and the case 2 expired in the 10 days after IVF. So it's a very risk, Chelsea, and we have made some prevention. However, the patient is fine despite our prevention. So we have to discuss: shall we treat the patient with Chelsea? My conclusion is we shall try our best to prevent complications, to minimize the severity of complication. Thank you for your attention.